Betty is a risk consultant from our malpractice liability insurance, MMCI. She's going to be talking to us about documentation and how it relates to lowering our risk for having problems. I'm going to let her tell you a little bit about herself, and then I'd like each one of you to tell her who you are and where you work. And be sure to sign in for nursing CEUs as well as register that you're here. So I think we'll go ahead and get started then.
Yeah, and I think there's an evaluation form that
Yes.
y'all get to fill out.
Grab those.
Welcome your feedback. As Judy said, my name is Betty Van Wert. I'm a risk and patient safety consultant with MMIC. And my background is in nursing, I was going to say now it's almost over 35 years, so I'm going to have to adjust my spiel of nursing experience. My background predominantly in women's health care, ambulatory labor and delivery, inpatient women's care, and also neonatal ICU and outpatient pediatrics. So mostly moms and babies and kids, and also some oncology background, but don't ask me to remember any of it right now because it changes so quickly and so rapidly that I have not stayed current with that at all. I graduated from University of Nebraska Med Center way back when, got my BSN there as well as my associate's degree, and but I have been in Iowa longer than I've been in Nebraska or Colorado at this point. So my background, most of my clinical work was in teaching hospitals, a couple of large university hospitals, as well as working with residents and that sort of thing, which I don't believe you guys work with, but they might be looking at doing some of that in the future. So today's topic, quality documentation and to patient safety. And objectives for today, by the time you leave, I'd like you to be able to cite 2 functions of medical records, as well as look at name 2 of the risks for patient injury or malpractice claims that arise out of gaps that we find in documentation. Identifying 3 of the 6, if not all 6, quality hallmarks of documentation, as well as discussing what can happen when there's incomplete or documentation that really doesn't meet the standard of any of those 6 hallmarks that we'll discuss. So in malpractice terms and patient safety terms, we talk about the 6 significant factors of malpractice. What are the things we see the most? What is most prevalent? Certainly we see malpractice, and there's a joke out there, cartoon among physicians that says, you know, what's good, what good is malpractice insurance if you don't malpractice once in a while? It does happen. Fortunately not with the prevalence that some people seem to think it does, but there can be communication breakdowns with the patient, the family, certainly within our own healthcare team that contribute to malpractice claims. There can be system failures. There can be gaps or drifting away from safe practices with our policies and our procedures. Informed consent is still an area of concern, making sure that patients have that opportunity not to just sign the paper, but to have that full discussion of their risks, benefits, alternatives to the treatment or surgery that they're considering undertaking. And have all their questions answered. And certainly we're going to talk about documentation today as the one significant factor that we're going to feature for today's talk. The purposes of a health record certainly is a legal record. It supports the care that was provided. Because a lawsuit can come up 3 to 4 years, usually on average, after the fact of the actual incident occurring, memories can fade. It provides information about, you know, what was the thought process that was going through, and, you know, where might we have gone awry, or was the thought process and was the execution actually on target with that documentation supporting it. There are patient safety purposes, such as making sure that we communicate with one another. Really, the medical record serves as a primary source of communication across the healthcare team, especially in acute care when I work nights and I can't be there when the physician rounds at 3 o'clock or 5 o'clock in the afternoon, or I work afternoons. I'm not there when the doctor rounds in the morning, or when physical therapy sees the patient. So making sure that we communicate via that means is very important. It gives a great deal of opportunity to coordinate and provide continuity of care to that patient that they're expecting. Certainly quality review, research data can be gleaned from the medical record, longitudinal look-back studies, and there are compliance issues around the documentation that we provide. We support the regulations, the credentialing. We support the reimbursement, really, when we document that something was provided. If a record is audited and there's nothing there to support the billing for a certain piece of the treatment or the equipment used, then that can be a problem for us. And within MMIC's data, we actually have problems with defending the care. Good care, oftentimes, can be difficult to defend. About 45% of the time, we've had difficulty with that. And these are deficiencies that, while they're prevalent, can be preventable, and that's part of today's purpose with today's education. As I mentioned, it can take 3 or 4 years after an incident before something becomes a lawsuit. Sometimes they wait to see, what's the extent of the injury over time going to be. Sometimes people don't realize they were injured, but it can take that period of time. Witnesses at that point, you can imagine you may have moved on, you may have retired, you may not remember that patient specifically or that specific day, or what you do remember of it isn't complete in your memory. You've seen lots of other patients, you've gone on lots of other vacations in that period of time, so you have an opportunity to not remember it as crisply as you would if you recorded it specifically at the time that it occurred. And that's really one of the chief purposes then with the legal record that the medical record provides. As far as quality documentation goes, the medical record, as I mentioned, again, run at home, primary vehicle for communication amongst the healthcare team members. If documentation isn't there, it can actually cause a patient safety problem. If I didn't record that I gave the patient an opiate an hour before I changed shift, and now you think, oh, they're asking for it, they haven't had it for 12 hours, I'll give them another dose, can end up with an overdose, respiratory suppression, what have you. Inconsistent documentation, habits that are, well, I'll chart at the end of my shift. And if your shift is 8 to 12 hours long, lots of things can happen, particularly with electronic health records now, with remote access to things. Physicians can pull up in their office when they've had a cancellation of a 10 o'clock appointment and see whether, what's the outcome, what's my patient's vital signs. Maybe she's hypertensive and I increased her dose of her hypertensive medication yesterday. I want to see what those results are. And if they look at the most recent recorded blood pressures and they're still elevated, they may actually increase the dose or change the medication, where in fact we just haven't given them the most current information. So having an inconsistent, untimely way of documenting can really cause some sloppy care to be implicated. Also, especially back when it was handwritten only, if the notes were sparse and illegible, you couldn't read them, even good care could be implied by the plaintiff's attorneys to be sloppy care based on the gaps in the notes. We can't even read it. Ladies and gentlemen of the jury, we can only imagine the sloppy care that my client was subjected to based on the sloppiness of and the lack of documentation presented in the record. So those are things we've actually heard people say. And sprinkled through today, I'll provide you some lessons learned. These are from our actual cases that have been closed, so there's no harm that can come of sharing the details of the case with you. They're also sanitized of any ownership of where they occurred. If they sound familiar to you, it's purely coincidental. These come from the states in which MMIC does business, which is the Dakotas across to Wisconsin, Indiana, skipping Illinois, Iowa, Nebraska, now Colorado, Kansas, and Missouri. So somewhere in there, these actually did happen as far as cases. So we'll sprinkle a few of those in for you. We're going to start with one that's actually kind of a good case. The facts of the case were that a 54-year-old retired school teacher had several polyps removed while he had a screening colonoscopy. The day after that, the patient presented to the local emergency department complaining of severe abdominal pain. A CT was done and it revealed a localized perforation in the right lower quadrant. The surgeon took the patient to surgery immediately, repairing the perforation, and the patient had an uneventful recovery. However, he still sued the surgeon for malpractice, claiming that that perforation resulted from negligence. And the experts who reviewed the case agreed that perforation is a known risk and that the surgeon recognized that complication in a timely manner, educated the patient as to signs and symptoms that he might be experiencing, that he should report immediately, all of that good stuff going on. And the surgeon's documentation was also very thorough concerning the informed consent discussion with the patient in regard to risks of the procedure. This claim actually was closed with absolutely no payment because, yes, there was an injury. Yes, it was a known risk complication. Yes, it had been foretold to the patient. Yes, the patient was educated. Yes, there was a perforation, but everything got taken care of very nicely. It wasn't based on the outcome that the patient, had an uneventful recovery. It was based on all the things that were done ahead of time with that. So, attorneys will look for red flags when they do their review of cases and when they ask for copies of medical records. They would look for alterations or the appearance of alterations in the medical record. Paper records, they used to look for whiteout. In electronic records, they're looking at late entries or addendums that are added to the record well after the fact and disguised as, oh, I put that in yesterday, or I put that in last week. But when you go into the metadata, which in electronic health records and electronic technology is the data about the data, so it says exactly when you entered the system, when you put that in there, even though you may have portrayed it as been a week ago. There is a way to do late entries and addendums, and we'll talk about that a little bit later. It's certainly very appropriate in some instances to do that, but you want to be upfront about it. You don't want to make it seem like you're covering something up. If there are contradictions or inconsistencies in the record, if all of a sudden if they were skin's warm, moist, and pink, and all of a sudden there's one entry for not so warm, clammy, pale, dry. So looking for inconsistencies in that. Full out omissions of documentation, full shift. Sometimes medical records are lost. That can happen as well. And you do what you can to recreate what documents you can with the best of your knowledge, but if there are complete omissions, that certainly is a red flag to them. Any time delays or unexplained time gaps, this can be important when you have a code in the patient's room. You've got a clock in the room. Is everybody using the same clock? Or does Better User Watch, which is set 5 minutes fast because I'm perpetually late to things, so I always try to fool myself. And the doctor is using his watch, which is 5 minutes slow, and so you have different times. We've actually reviewed a medical record where, best as they could, as they didn't have anybody to record the code, writing, they take the writing down from their arms and down the scrub pant leg and everything else, and they congealed it as best they could, and what order we did everything. But what happened was we used different clocks. And so it would actually appear that for 5 minutes people stood around and waited and watched and didn't do CPR, didn't initiate things. So there was an unexplained time gap in that particular record. And then one of the things that's really getting a lot of attention is copy and paste, or sometimes it's called cloning. Just like in Excel programs or Word documents, you can copy and paste to some limited degrees and varying degrees depending on the vendor of your electronic health record. And so some very really smart people who want to really save a lot of time and who also recognize, oh, that was a great admission note, or that was a great note yesterday, that particular physician wrote, or the resident before me wrote, and I'm just going to copy it, or maybe I even wrote it. Maybe I'm not plagiarizing. Yesterday's note was so good, I'm just going to copy it and paste it and then do the updates. Well, what happens is it virtually looks verbatim to the previous note. And you may get interrupted, you may forget where you are, oh, I didn't update that piece, and then you save it and it goes into the medical record. And so attorneys will hire people to go through, just like high school teachers. I have a friend who teaches literature, and she has papers written, and
And they have a tool to their disposal that can identify, and it's really quite easy to do. You copy it, paste part of it. You can tell which students have plagiarized papers previously written on the internet. And they also have a storage of previously written papers from students from the previous year, previous 2 years, if they've copied and pasted that. Yes?
So how do, a lot of physicians will use like templates,
Mm-hmm.
and you kind of get in the habit of your spiel.
Yeah.
So how does that play?
If
I
it's
mean,
absolutely verbatim, that's how you find the difference. The spiel can be very different than an absolute copy paste. I mean, the punctuation, every misspelled word is exactly the same.
Right.
So, yeah, that's how you can tell. But yeah, everybody's a 81-year-old white
Yeah.
female, blah 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 blah. Yeah, yeah. There are some subtle differences that you can find with that copy and pasting, because they don't always, when you dictate them, fill the lines in exactly the same way. But copy and paste is pretty much identical. So, it's receiving a lot of national attention. It is frowned upon. It is a time-saving device, but it should be very limited, very controlled circumstances, making sure that those people don't have any interruptions whatsoever, which is hard to do in healthcare because people code off schedule and those sorts of things. I mean, you know, when's the last time you said, okay, 2 o'clock, we're gonna have a code, you know, unless it's a drill or a simulation. You just don't have those opportunities in healthcare, so. All right, so some common errors that we're finding in documentation that we've reviewed. Failing to record pertinent health information as far as health history, family history, failing to record nursing actions, things that you've done for the patient. We get into that checklist mentality, and especially the electronic health record, and you're checking the boxes, but maybe there's not a box to say, you know, applied warm, moist heat. So it just doesn't happen because it's not in there. Failing to record medications, and I spoke to that a little bit earlier, particularly risky with PRNs and opiates. Recording on the wrong record still happens in electronic health records as well as paper records. You still need to look for those 2 patient identifiers to make sure. In EDs, where we see this fairly prevalently because you've got maybe 2 patients involved in an auto accident, and they got 2 records open because it's easier, and I'm going to go record on that one, and I'm going to go record on that one, and maybe unbeknownst to you, the PA or NP brought up the other patient on the other record, and you're thinking it's that one. You can have 2 people the same name, junior and senior. You know, check that date of birth. That'll give you a good clue as to whether or not you've got the right record or not. Failing to document a discontinued treatment or medication goes back to transcribing orders improperly, and then failing to record a response or actions, changes in condition. Let's see. Certainly, you know, when you give a pain medication, when you've done some sort of a comfort measure, when you've applied oxygen,